Welcome, everyone. I'm Leslie Verner, Director of Programming for Carolina Breast Friends. We are so pleased to have Dr. Katherine Moore and Dr. Dipika Misra with us again today. Both are board-certified medical oncologists and partners at Novant Health Cancer Institute. Dr. Misra came to Charlotte in 2010. Dr. Katherine Moore came in 2014, and they both specialize in breast cancer. It is a pleasure to have both of you with us today. Thank you so much for being here.
Thank you, everyone, for having me. It has been a while since I have been able to go into the Pink House, but I can tell you that I have spoken in the Pink House several times over the past few years, and it's always been a lovely environment. We've always had great conversations. So I hope that we can continue to have this in the virtual setting as well. So today, Dr. Moore and I thought that it would be helpful to speak about updates in early stage breast cancer. Like Leslie said, I have been practicing breast oncology in the Charlotte community for the past 10 years. And I can tell you during this time frame, we've made amazing advancements in breast cancer, and it has been so rewarding to be a part of this improvement in care, and to be able to see our patients do better and feel better as they're going through treatments. And I think a lot of this is from the research that is ongoing. So we decided that we were going to first talk about updates in early stage breast cancer, and if everyone enjoys the talk, we can at a later time do a similar sort of presentation in the metastatic breast cancer group as well. And so just to start out very general, and recognize that everyone is coming to breast cancer at different stages in their journey. So just to really explain what is breast cancer. Breast cancer is a proliferation of abnormal cells, and this can be in the ducts, or it can also be in the lobules. The lobules are where milk is made, and then the ducts are where the milk is passed through up to the nipple. And so normally we have cells that are sort of lining those ducts, and it is normal for there to be some hyperplasia or proliferation of cells. The point where we get concerned is when we start seeing atypia or abnormal cells starting to develop in either the ducts or lobules. Now, this doesn't indicate cancer per se, but it does start raising concern for possible cancer around those areas. And then as we go on in the spectrum, we become more concerned when we actually see cancerous cells within the ducts, and that is called ductal carcinoma in situ. And that is treated typically with lumpectomy. And then we talk about radiation and sometimes anti-estrogen therapy to reduce the chance of this coming back. And then the point where we actually talk about stage 1 to stage 3 breast cancer is when we actually see that these cancer cells invade through the basement membrane and go into the bloodstream. And this is a picture of microinvasion and then invasive duct cancer. So these two entities are where we see the stage 1, and then moving on to stage 2 to 3. Ductal carcinoma in situ is considered stage 0 breast cancer. And please feel free to stop me at any point if I confuse anyone. Like I said, I really want this to be an open forum, so I'm happy for questions to come up as we're going through these slides. So the first update that I wanted to discuss is changes that we're making in terms of prevention of breast cancer. So, when a woman is diagnosed with either ductal carcinoma in situ, like I said, the stage 0 breast cancer, ADH or atypical ductal hyperplasia, or have a strong family history of breast cancer or genetic predisposition, we are, as medical oncologists, starting to offer different types of anti-estrogen therapy. And the most well-studied anti-estrogen options are tamoxifen, 20 milligrams. And then for our postmenopausal women, what has been the best studied has been raloxifene, exemestane, and anastrozole. And all of these drugs have shown almost a 50% reduction in the incidence of breast cancer with these anti-estrogen therapies. But over the past 2 years, there was a very interesting study that was conducted in Italy of about 500 patients where they actually used a lower dose of tamoxifen, almost a quarter of the standard dose at 5 milligrams a day. And they showed a similar reduction in the risk of developing breast cancer. And these curves show almost a 50% reduction in the development of breast cancer in these women who had either strong predisposition to breast cancer or DCIS.
Turning that parking lot.
And then this was also seen in the contralateral breast as well.
This used to be a ponderosa or something.
So where there was a contralateral, or there was reduction in contralateral breast cancer events as well. Now, what was really interesting about this trial was that the side effects of for patients with this lower dose of tamoxifen was less. So there was almost equivalent incidence of blood clots or pulmonary embolism as patients who had just received placebo, meaning just a sugar pill. So what that tells me is that really the tamoxifen 5 milligram in this small group of patients, of about 500 patients, did not increase the risk for blood clots or pulmonary embolism or DVTs. But there was one patient out of this 249 cohort of patients that developed endometrial cancer. So again, a very small incidence compared to what we see in patients who are taking tamoxifen 20 milligrams. But what was also important to recognize is that, you know, the biggest things that we see with tamoxifen that we probably see in our clinic and are struggling with are the complaints of hot flashes, vaginal dryness, arthralgias. And what they showed, this curve shows the women who had received tamoxifen and then the women who had just received a sugar pill or placebo. And they did show that those women that took tamoxifen had a higher incidence of hot flashes in terms of frequency and intensity. And then there was but when you looked at vaginal dryness or musculoskeletal pains, there did not appear to be any significant increased incidence. And so I think this is another option for our patients who want to be proactive and try to prevent developing breast cancer with this lower dose tamoxifen. Now, I want to make clear this is not for a patient who has already been diagnosed with breast cancer. It's more for the for either those patients who are at higher risk, or we are considering it for our stage 0 breast cancers, but not our stage 1 to 3 breast cancers. Now, moving on to our invasive breast cancers, I put up this slide to reflect what we're starting to understand in breast cancer. We recognize that breast cancer is not just one disease. This heat map shows you all the different genetics that are involved in all different types of breast cancers. And so what we're seeing is that that we have divided these breast cancers into really 4 subgroups. That's sort of the simplistic way, but even in these subgroups, I think we're starting to learn more about these cancers. And I think as years go by, we will find that we will have even more subgroups of breast cancers. So just to be very clear, I think the way to think about breast cancer now is to recognize that there are ER positives, HER2/neu negative breast cancers, ER positive, HER2/neu positive breast cancers, ER negative, HER2/neu positives, and then our triple negative breast cancer. So in this talk, I was going to focus more on the ER positive, HER2/neu negative breast cancer updates, and then Dr. Moore will go on to speak to the HER2/neu positive and our triple negative breast cancers. So the name of the game in breast oncology is targeted therapy. And really that has been shown to have the most benefit in terms of reducing side effects of therapy and also to improve outcomes. And so our biggest target in breast cancer is the estrogen receptor. And as most of you may know, the primary anti-estrogen therapies that we use in breast cancer are tamoxifen, which we primarily use for our premenopausal women, and then aromatase inhibitor for our postmenopausal women. And the aromatase inhibitor, the names of those drugs are anastrozole, letrozole, and exemestane. So tamoxifen works directly on the estrogen receptor, and it helps to block the estrogen receptor and prevent transcription of those genes, so it prevents the cell from continuing to grow. While the aromatase inhibitor actually blocks the production of estrogen. So I have several women who are postmenopausal, and they come to me and they say, I'm not making any estrogen. Why do I need to take a pill? How can an anti-estrogen help me? My ovaries are no longer working. Well, women are still, even postmenopausal women are still making estrogen from their bones, their adrenal glands, their fat. And what they're doing is they're producing androstenedione and testosterone. And with the use of the aromatase enzyme, they are turning those hormones into estrogen. So that's what the aromatase inhibitor is doing. It's preventing actually production of estrogen. So in terms of updates in early stage ER positive breast cancer, what I was going to specifically talk about today is the Oncotype DX assay, which we are starting to use as a way to tailor therapy in patients who have node negative and node positive breast cancer. The reason we can do this is because of how effective our anti-estrogen, our targeted therapies are with tamoxifen and aromatase inhibitors. And this is starting to allow us to not have to give chemotherapy to all our patients. I can tell you about 20 years ago, most women with breast cancer were getting chemotherapy. And we have come a long way where we can start sparing women from needing chemotherapy using the Oncotype DX assay. And then I will go into some newer data on the use of drugs called CDK4/6 inhibitors, which have been well established and studied in our stage 4 breast cancers, and sort of talk about how we're starting to incorporate these drugs in more of our earlier stage breast cancers to improve outcomes. So let's start with the ER positive, node negative breast cancers and use of Oncotype. Many of you may have heard of Oncotype. Oncotype is where we extract the DNA from a tumor and we actually look for certain genes, and these are the genes that we look at, and we create a score based on those genes. And so the landmark trial that was kind of presented over the past 2 years was the TAILOR-RX trial, which looked at patients with ER positive, node negative breast cancer and actually used the Oncotype to determine the benefits of chemo. And so for those of you who've had to have an Oncotype score sent, this is the way the report looks. So what you get is a recurrent score, which is that calculation based on the DNA marker. You get a recurrence percentage if you were to take anti-estrogen therapy alone without chemotherapy, and then you get a percentage of the degree of benefit of chemotherapy. And the score can be from 0 to 50. So in this woman, she had a fairly high score of 32. And so the discussion would be on chemotherapy because based on the DNA and those genes, we would say that she would benefit from chemotherapy. I like this slide because it sort of shows how women were determined to benefit from chemotherapy or not. So the way that these trials were conducted initially, before we knew whether chemotherapy was needed for everyone, was that half of the patients would get chemotherapy plus anti-estrogen therapy, and that's these patients on the dotted line, and half of the patients would get anti-estrogen therapy alone, which is on this solid line. And so if your score fell less than 25, the difference between these two curves are fairly small, and at most maybe 3-4%. But as the score becomes higher, the curves get farther apart. And that's how we can say that chemotherapy actually has a benefit. By giving chemotherapy, we reduce the risk of recurrence by this percentage. And so the Taylor RX among women over the age of 50 showed that patients who had a recurrence score of less than 25 really had no benefit from chemotherapy if they were node negative. If you were greater than 25 on the recurrence score, then yes, you would have benefit. For patients under the age of 50, we still have a little bit of work to do, but there appears to be some benefit of chemotherapy, even in patients with lower scores of 15 and above. So we're starting to use more clinical markers of grade and size of the tumor to help make these decisions. How's everyone doing? Is everyone understanding what I'm speaking of? Is there any questions that have come up? Okay, it's a little bit different just speaking, because I can't tell if everyone's following, but I'm just going to keep going. And please, again, feel free to speak up if I've lost anyone. So now I'm going to go on to our ER positive, node positive breast cancers and the use of Oncotype. So this is a really exciting thing, fresh off the press. This was presented at our national meeting this past December. I don't think they have even published this data, but it's already being used in clinical use in our patients. So this is called the RxPONDER Trial. And in this trial, it justified how we can make decisions for chemotherapy or anti-estrogen therapy alone among patients who had lymph nodes that were positive. So what they did is they took women who were over the age of 18 who had ER positive, HER2 negative breast cancer and 1 to 3 lymph nodes. And these were all women that could receive chemotherapy and had no evidence of any distant metastases. If their score was greater than 25, they automatically got chemotherapy and anti-estrogen therapy. But if their score was less than 25, they were either randomized to chemotherapy followed by anti-estrogen therapy or anti-estrogen therapy alone. And what they showed is that women who were postmenopausal and had an Oncotype score less than 25 had really no benefit from chemotherapy. And this is huge because I can tell you up to 2-3 years ago, we were giving every woman who had node positive breast cancer chemotherapy. And now I can say that I can say that not every woman needs chemotherapy, even though they have lymph nodes positive. Now for premenopausal females, it's still a little different. I think regardless of the Oncotype score, we are seeing that women who are premenopausal still have a significant benefit of chemotherapy. That's about a 5% difference. So I think that is the reason why some women who are older may be spared chemotherapy with lymph nodes positive. And that's sort of the new findings, but we're still in our premenopausal women still need to give chemotherapy for our node positive because they do benefit from chemotherapy. And then finally, I was going to speak about CDK4/6 inhibitors. So like I said, CDK4/6 inhibitors have been a great advance that we have made for our stage 4 breast cancer patients. And the way it works, just to review again, the tamoxifen and another drug called fulvestrant, they actually physically block the estrogen receptor. The aromatase inhibitors block the production of estrogen. But sometimes the cancer cells, they can still be sneaky and they can bypass this way of proliferation by activating other pathways. So cyclin CDK4/6 inhibitors blocks the cyclin D pathway. So it blocks the cell cycle pathway in another way and helps prevent cell cycle progression. And so in combination of anti-estrogen therapy and the CDK4/6 inhibitors, we can actually see that patients do better in stage 4 breast cancer. There is better response rates with these combination of drugs. And so the thought was that, well, maybe we can cure more women by giving these drugs together in our more advanced early stage breast cancer. So this was again a hot off the press from San Antonio Breast Cancer Symposium in 2020 called the Monarch E trial. And in this trial, they took high grade and more aggressive tumors with lymph nodes or grade 3, and they randomized them after they had received chemotherapy to either just anti-estrogen therapy alone or anti-estrogen therapy with a drug called abemaciclib, which is, like I said, a CDK4/6 inhibitor. And these women took this drug for 2 years. And what they showed is that there was a benefit. This is the curve of women who took abemaciclib plus anti-estrogen therapy. And this is the curve of women who just took anti-estrogen therapy alone. And you can see that there is a separation of the curves now, almost 2 years out, of about 4%. So there is what looks like a disease-free survival benefit of anti-estrogen plus the abemaciclib. And it's something that has not been FDA approved. It is not something I'm offering to all of my patients yet. I have offered it to a handful of patients who I believe have a higher risk of recurrence. And based on this data, I'm hoping that this will help prevent recurrence even more. But we do have to have a frank discussion with our patients about the side effects and really understanding whether we want to take the risk. But it's something exciting, something to come potentially in early stage breast cancer. And then with that, I'm going to stop sharing my screen and I'm going to have Dr. Moore take over. But I just wanted to, again, reach out, make sure that there's no other questions before that I can answer.
I did have one question. Is this all including radiation, or in conjunction with radiation?
So,
or, I mean, because, as I understand, that's part of the equation for treatment.
Yeah, so all of these trials that I presented, women got standard radiation. So if they would have gotten radiation normally, they got radiation with these treatments as well.
All right, thank you.
Yeah.
I have one question, Dr. Misra. If a postmenopausal woman has bilateral mastectomies for LCIS, is there any reason for her to take an aromatase inhibitor if her breasts have been removed to prevent a future recurrence of the breast cancer anywhere?
I think that the degree of benefit would be too small to justify the side effects of anti-estrogen therapy. She's probably made the most definitive treatment with bilateral mastectomy. And I think the risks are exceedingly low, if any, of the cancer recurrence with LCIS.
Okay. Thank you.
Anything else? And so Dr. Moore and I plan to also open up to just questions from the audience that we may not address with these slides. So we can also do that as well.
I have a quick question too. You said that this last treatment that you were suggesting, you said that there are side effects with it and you have to, discuss that. What are the side effects to that treatment?
Yeah, so side effects of abemaciclib are diarrhea, which I think is probably the most bothersome. And we see that that diarrhea symptom actually lasts for it's actually in its most intense phase in the first 5 weeks. So we are managing with Imodium and another drug called Lamodal. We also see that the blood counts can drop, so it does require more monitoring. And really, it has to be a patient that's motivated to try something else other than anti-estrogen therapy alone. And it has to be a patient that has a high enough risk to justify these side effects, because it's much more doctor's visits as well. But the two biggest things are blood counts, diarrhea, and fatigue.
And again, that was for, was that for node involvement?
Right. So the trial really used patients who had higher risk disease. So they either had more than 4 lymph nodes at the time of surgery, or they had grade 3 disease and 1 to 3 lymph nodes. So high grade disease and 1 to 3 lymph nodes.
Okay, thank you.
Dipika, I think you have to stop sharing for me to share.
Yes.
Okay. So, just to kind of go over a little bit of terminology, so adjuvant, or what we consider after surgery treatments. We also use the word neoadjuvant, which is when you're doing any kind of treatment before. Typically, we think of treatment as being, if you're doing neoadjuvant, it would be chemotherapy and then surgery, and then adjuvant treatment would be if you have disease still present on any pathology. So that's something that a lot of the next treatments that I'm going to be kind of going over will kind of talk about what kind of adjuvant options are going to be available. And so the question is kind of what else can we do? So, we always want to try to be a little bit greedier. We always want to try to get a few more, percentage points in terms of survival. And so, kind of the 3 big things that I think Dipika had kind of hit on a little bit that I will talk about is, she talks about the ER/PR positive breast cancers, but then I will talk about the HER2 positive breast cancer. And we'll go into TDM1 or Kadcyla, and then triple negative breast cancer with Xeloda and capecitabine. So just a little bit of a schema of triple negative breast cancer. So this is, the NCCN guidelines, which is kind of one of the major guidelines we kind of look at and kind of review when we're talking about treatments. So
Dr. Moore, I'm sorry to interrupt, but we can't see your slides.
Oh, I wish you had said something. I didn't have a problem earlier. That's interesting.
That's all right. There you go. This is looking promising. There you go.
The joke is always that Dipika is the more technology one that struggles. So I don't think she's going to let me live this one down. Okay, so this is kind of what I was talking about. So if what I was saying kind of made sense there. Yeah, please always feel free to interrupt me. So systemic adjuvant treatment options. So, a lot of times we weren't even thinking about doing chemotherapy years ago, for patients. But what's been the nice thing is that, now that we are doing chemotherapy up front or kind of prior to surgery, we now have a lot of these options that we can give to patients after surgery. And so that's one of the benefits, that we have in terms of doing kind of these neoadjuvant treatments or kind of these pre-surgery treatments. It kind of allows us to really understand the biology of somebody's cancer or somebody's disease. And kind of by doing that, depending on how they respond, we can kind of make a lot of decisions after treatment. So if someone responded well and they get a PCR, what we call a pathologic complete response, then, we feel much more comfortable that maybe adding on additional treatment is not necessary. I think that sometimes less is more is really one of the nice things that we're kind of learning in oncology. And, we always want to be as aggressive as we can, but, we certainly don't want to do it to the detriment of the patient. So if we're kind of looking here, it always used to be, let's look at the pathology and let's look at the kind of the tumor size and then kind of make the decisions and kind of the recommendations. And that's really not kind of how we're looking at things anymore. Now, when it comes to triple negative breast cancer, as we're talking about neoadjuvant chemotherapy, this is not FDA approved. I will not spend probably a lot of time on it, probably particularly for that reason, but I think it's pretty interesting and pretty exciting. It is immunotherapy for patients kind of in the pre-surgical setting. So there is, I guess to kind of back up on immunotherapy a little bit, there are 2 immunotherapies now that are FDA approved in the metastatic setting only for triple negative. There are no immunotherapies that are approved in the either ER/PR positive, HER2 negative, or just in the HER2 positive setting. So when we were kind of looking at this, we have, I don't know if you can see my pointer here. Yeah. So we have Pembro or pembrolizumab is what this is kind of standing for. So this is the immunotherapy portion, and then followed by, given in conjunction with a medication called carboplatin and paclitaxel, and then pembrolizumab with doxorubicin or epirubicin, which is frequently given in Europe, and then cyclophosphamide. So for anyone who has received dose dense, this is very similar, but you can see that they did actually give the carboplatin as well, which is not necessarily the standard of care. It is, I would say, not controversial, but I think very dependent on several factors. And then it is not uncommon that if you're giving carboplatin, that we are now kind of trying to give the carboplatin up front, and then giving the adriamycin and the cyclophosphamide second. And then you do surgery, followed by additional pembrolizumab. And then this was a similar schema minus the pembrolizumab. So what we found, though, was that patients with triple negative breast cancer who achieved a complete response with the pembrolizumab was significantly higher compared to those patients who did not. So one of the reasons we are, still waiting for data to mature here is they're kind of waiting for some additional survival data. But I think we're certainly enthusiastic. I know that at least anecdotally, we have seen some excellent responses in patients, but I think certainly something exciting to kind of come down the pipeline for patients. And, immunotherapy, it's unclear if and when it's going to be kind of coming for other types of breast cancer. I think just the biology of triple negative breast cancer is so different than all other breast cancers. So not surprising, at least from a medicine standpoint, that it's being given in triple negative. And so I think it just kind of shows that, as Dipika had kind of showed with the 4 kind of subtypes, yes, it's all breast cancer, but they really act so differently and they are so different. So it's so hard to kind of lump them all together. Kind of on to a second kind of topic, but still within the triple negative realm. So for patients who receive neoadjuvant chemotherapy, so again, chemotherapy prior to surgery, if they do not receive a complete response, so a non-PCR, so that's what that kind of stands for, a major consideration is to give adjuvant capecitabine. So we have for HER2 negative, the study was given where you get patients receive neoadjuvant chemotherapy. This was actually for all comers. So it also the study did include patients who were estrogen and progesterone positive as well. They then underwent surgery. So pathologic non-PCR patients, and then the patients were then randomized into a control with standard therapy. So for some patients that would be, either hormone therapy or kind of no further systemic therapy. And then, I think as one of the questions had alluded to, if they were going to receive radiation, they would have gone on and kind of received their radiation therapy. And then, the standard therapy plus capecitabine. The capecitabine is given for 6 to 8 cycles, which usually is, 4.5 to about 6 months. Capecitabine, another name for that is also Xeloda. It is an oral drug that's given. The biggest side effects we tend to kind of see with that is really diarrhea, and then kind of hand-foot syndrome, where we see a lot of like drying and cracking and redness, peeling of the hands and of the feet. So what we have here, and a little bit of an easier schema to see and to follow, is again the patients for triple negative did have an improved disease-free survival. So, the patients for hormone receptor positive, it was actually found to have no benefit. And so you will find some physicians that have, I think, a little bit of bias towards potentially considering it if there's a significant amount of residual disease. But, I don't think we necessarily need to kind of go into the nuances of that. But this is really, again, one of the biggest benefits of talking about and doing, besides, maybe, downstaging and trying to make surgery easier and things like that, but of doing surgery up front and really understanding the biology so we can give treatments, such as this. And then really the last thing that we'll kind of go into is another adjuvant trial for patients who would receive a neoadjuvant chemotherapy, and it's called the Katherine Trial. And so, again, this is kind of taken from the NCCN guidelines. So we have patients who are either HER2 negative or HER2 positive, or hormone receptor positive and HER2 positive. And for those patients, if they receive neoadjuvant chemotherapy, oftentimes they would have received a 4-drug combination, and it would include Herceptin and Perjeta. And so if they were to go on to receive for either one of these chemos, they would have gone on to receive an additional year of the Herceptin and the Perjeta, or the trastuzumab and the pertuzumab. But for patients who continue to have residual disease and did not receive a pathologic PCR, so this is kind of what this ends up representing, is either lymph node positive disease or really any residual disease when the pathologist was looking at it. The patients, the recommendation now is that they receive what's called trastuzumab or Kadcyla. So, or TDM1 is also another name that we frequently use for that. And so, this is one of the graphs from the trial that was presented. And what we can see is that there was a 50% reduction in the risk of recurrence. And, at the time of the trial, one of the arguments you could make is that it was only Herceptin that was given versus Kadcyla. There's, again, some kind of nuances there. But nonetheless, we still feel very strongly about this data. I think it is a significant benefit to patients. So we, Herceptin or HER2 positive based cancers, I think years and years ago, before we had some of the treatments that we have now, I think was thought to be much more of a negative thing. But quite frankly, I would never wish for anyone to have any of these, or certainly HER2 positive treatments. But the treatments that we have against it now are really so quite effective that there's a lot of confidence that we have in these drugs. So As soon as we get the pathology, we kind of look at it and immediately kind of talk to the patients. And if really with any amount of residual disease, the recommendation is to kind of move on for additional treatment. So, I think really the take home is, not all patients are going to qualify though for neoadjuvant or for, pre-treatment chemotherapy. Just the reality is not all patients are going to need chemotherapy. I think the other hard thing is that we don't always know the treatment that someone's going to need beforehand. And so we would never want to give somebody a stronger level or a higher level of treatment than they were to need. So sometimes we really do need that surgical pathology to be able to decide or determine which chemotherapy is going to be best for them in the end. And sometimes that's just not something that we have enough information pre-surgery to decide. Occasionally you can talk about Xeloda if you were, to want to do that. But again, it's off trial, so it really would not be recommended. And Kadcyla would also not be something you consider. But nonetheless, I think trying to implement as much treatment as you can early on is really the primary recommendation. So any questions or?
Does the audience have any other questions for us that we can answer? Honestly, it could be related to this or to anything.
I have a general question. Dr. Misra, it's Beth Pickering, your patient.
Yeah.
You may recall that I choose to blame my triple negative breast cancer on the 10 years of hormone replacement therapy that I was on for menopausal symptoms. So my question is just, what is the current thinking about the relationship between hormone replacement therapy and an increased risk of breast cancer?
So there's definitely an association. What I have seen is that, really the association is when women are on hormone replacement therapy and there is a higher risk of breast cancer during that time frame. And not necessarily having had a history of hormone replacement therapy before. Now, it is still unclear how triple negative breast cancers develop with hormone exposure or excess hormone exposure, but theoretically, you're stimulating that breast tissue to form these abnormal cells, and at some point in their development, they've found a mechanism of action to grow even despite taking away that excess estrogen. So they develop their own biology, and that's why they don't express estrogen anymore and become triple negative breast cancer. So I think that in your case, I probably would say that it may have contributed to your breast cancer.
Okay. All right. Thank you.
Katie, what do you think about it?
Yeah, I mean, I think that it's controversial, but I think the studies are just hard to fully pin down because the retrospective nature of many of them. But I think Dipika kind of hit the nail on the head when she said that the kind of the downregulation of the estrogen receptor. So when you kind of lose that, when you've had the hormone replacement therapy, so you then kind of that can kind of lead to the increased risk. But I think that it's also so hard because so many women also have so many risk factors, and then they don't they don't develop breast cancer. So I think there's just so many other things that we don't understand about it. So I always hate to say it's one thing that somebody did or didn't do.
Thank you.
We do have 2 questions in the chat. One is, have there been changes in the length of the time to take tamoxifen? This patient started taking it and was initially told 5 years, and now she's hearing 10 years. Have there been any changes to that?
Yeah, so there have been 2 trials, one in the UK and one in the US, called ATOM and ATLAS. And in both trials, they took women and they offered them either the standard, which is 5 years, or the extended dosing of 10 years. And what they showed was that there was not only less incidence of breast cancer, but patients actually lived longer. It was about a 3% difference. It took almost 15 years of follow-up to show this, but now we have 2 trials that have shown that that benefit.
Okay, and the other question, actually we have 2 more questions. Is HER2 breast cancer, HER2 positive, still 25% of all breast cancers?
Yes. Yeah.
Okay. And then the next question is, what do you think about any of the low dose considerations for vaginal atrophy associated with tamoxifen, such as Vagifem and or estriol?
So, you know, the NCCN guidelines, you know, recommend trying to use some kind of, you know, lubricant first and foremost, but I think realistically, it just doesn't work for most women. I think it can work during intercourse, but quite frankly, I mean, there are, you know, many other hours during the day and the week that it still just is a major problem or an issue. So, you know, I do like to try to recommend things like the Mona Lisa procedure, but it's just not always realistic. Just, you know, from a financial standpoint either, I really wish things like that would be, you know, covered financially, because I do think that it is a major medical problem and issue. I don't want to get on my soapbox. Well, I think some things for men are covered, but they aren't for women. But nonetheless, you know, I think that we probably worry about it a little bit more than we should. I think that there is some absorption of estrogen, but I think that it's probably pretty minimal. So, you know, the recommendation that I give my patients is that, you know, try to use it, you know, as sparingly and as minimally as you can. But at the end, you know, it's a quality of life issue. It's a major quality of life issue. And so, you know, there has to be some comfort there too. So Intrarosa is something that I have tended to kind of lean more towards, which is more kind of DHEA, you know, based, a little more kind of testosterone, but it, as you kind of saw in one of Dipika's slides, it gets converted into these estrogens anyway. So that's kind of where I stand on it.
What other questions does everyone have? I don't have anything else in the chat, so feel free to unmute yourself.
I have a question unrelated to treatment, but my question is, I'm going to make the presumption that Novant has a tumor board. My treatment was an LCI, and there was a tumor board, and I'm kind of wondering what that looks like. It was never explained to me because I didn't ask, I guess. But how many people sit on a tumor board, and do you guys have little paddles that you raise, you know, yes, no, do this, don't do that? How does, you know, I know it's kind of, I'm kind of picturing something really silly, a 10, a 5, whatever. But how does a tumor board work as far as making a decision on treatment for a patient?
It's actually very similar to what we're doing now, at least now in the COVID setting. We have actually a medical oncologist in the Novant system that span from all the way from Huntersville all the way down to Matthews. And then we also incorporate some occasionally our Winston-Salem colleagues. So it's really all of the medical oncologists, the radiation oncologists, surgical oncologists, we've been doing pretty much solely Zoom for the past year. But it is sort of like that. We survey the whole group and try to get everyone's opinion. I don't think we take a vote necessarily, but we can get a good sense of everyone's agreeing with the recommendations, or if people have different thoughts.
So are some of them mostly a slam dunk and they're going, yep, do this, do that? And some of them are, well, we don't really know, or.
Yeah, it can be a 2-minute conversation, or it can be turned into a 20 or 30-minute conversation.
I kind of also picture everybody having buttons and they get to vote, yes.
A button would be great. It would be much easier. I actually run our program here at Novant, and sometimes I have to keep the show moving. We have a lot of cases, so but yeah, a button is a great idea. I should bring that up next.
Dipika has a timer on us, and she
And does it
keep us in track.
Does it meet once a week, or does it meet sort of as needed, or?
Yeah, we meet once a week.
Okay.
Yeah, and we review all the pathology, the radiology.
But it's medical oncology, it's radiation oncology, it's surgical oncology, the nurse navigators, and then sometimes the nurse practitioner. So we have a very active nurse practitioner, and she does a lot throughout the institute, but she's really does a lot of breast. So I don't know if any Megan Kalamusa, so she participates, and then we have radiology, we have pathology, and sometimes there's multiple radiologists and pathologists and things like that. So I know that there's probably other people I'm forgetting. Genetics is on, so
plastic surgery.
Yeah, plastic surgery, and so it's nice to get opinions from everybody. And I think with Zoom, in some ways, we've always had the Zoom component, but I do miss it in person a little bit. But we'll get back there.
So how many people are typically, and I guess the reason I ask this because is when I talk to somebody who's newly diagnosed, and I'm trying to reassure them that, it's not just the physician, the oncologist, the surgeon, or whoever that you've been assigned to or you've picked out, that there's, I like to reassure them that there is this tumor board, and that they, a lot of doctors and medical staff are getting together and discussing it. So how many people typically sit on a tumor board?
I would say
I think like
50 or 60.
when we do the Winston-Salem ones, it can be 70 or 80, if 90.
Wow.
There's a lot of people there. So, one of them's at noon on Wednesday with the Winston-Salem, and there's one at 7 a.m., which is much better attended. Sometimes the lunchtime one can be hard to rush to, but
so you don't want to be on the noon one because it's
that's the Winston-Salem time, for the record. We chose to we like the early morning one. So
okay.
I'm kidding. But yeah, and honestly, quite frankly, I can't tell you the number of times I've gotten home late because Dipika and I are just sitting and talking about cases, or we message each other, obviously not giving any identifying information about patients, just talking and asking opinions for a lot of the breast oncologists within Novant. So, it's really quite collaborative.
Yeah, and for me, that would be quite reassuring because, again, sometimes I think you sort of get assigned a physician or several physicians that you don't really know. And again, and I think people have, I asked about mine before I selected them. But I think some people are going, I don't know because I didn't have a choice and all that. So I think to me, that would give a lot of reassurance and a lot of comfort knowing that other people are involved in giving a thumbs up or a thumbs down or sideways or however you guys do it on the treatment. So thank you for that.
Yeah, of course.
I'd just like to say, if I could, thank you very much for the presentations. I learned quite a bit today. But I do have a little question here for Dr. Misra, if I could, because my diagnosis was 18 years ago, and I had the ER positive and HER2 negative. So thank you for explaining that. I just opened up my eyes on everything. I've gone through the whole thing. I had the lumpectomy, I had the chemo, the radiation, then chemo again. And I had the tamoxifen after that. So before everything was, thrown at me. So what brought to my attention during your presentation was that you said there was a threshold of a positive node of 3 or more. I had actually 11 nodes that were bad out of 28 that they removed. They just carved out a whole bunch from that time. So now going from premenopausal to menopausal, should I be looking at some other preventative, what is it called? Anti-estrogen suppressor, or should I just stay as I am because I am just feeling good and healthy? And if I could not take anything, I would rather not. I'm just going for my regular mammogram right now.
And how long ago did you complete tamoxifen?
I completed it, so it was 2002, 2003, went through all of that. And from 2003 on, 5 years, I've only done 5 years of tamoxifen.
And now you're almost 10 years out without any, well,
Over 10, yeah.
how many years out from your original?
18.
18 years.
Yes.
Well, that's wonderful. I'm glad that your cancer has not shown any signs of recurrence. It's a tough question that you're posing. And the problem with estrogen receptor positive breast cancers is they can come back years later. And that's always our concern with ER positive breast cancer. But honestly, I don't have any data to say we should start you on an anti-estrogen drug now, and I can't quantify how much benefit you would have. I would like to say biology wise, you're 18 years, and I think you've pretty much done what you've needed to do. Obviously, if you were diagnosed now, we probably would have extended your anti-estrogen therapy. We would have given you 10 years of anti-estrogen therapy, and that's what's recommended by our national cancer guidelines. But I don't have any data that looking back on a patient who's 18 years out saying you need anti-estrogen now. And I don't know that I can say that you'll have a significant benefit. I may be putting you through more side effects than benefit.
Okay, thank you.
Yeah. That's a tough question. Dr. Moore, what do you think?
I was grateful that she asked it to you. No, I mean, I completely agree. I mean, I think it's hard. We always talk about too, when we're talking about these adjuvant treatments, that, oftenly kind of doing them, especially even chemo within 6 weeks of surgery, and kind of doing them sooner. So the idea of trying to implement a treatment now, it's kind of the idea of doing something feels good, because, well, sometimes, obviously not for the person who sometimes has to have the side effects, but it feels like we're being proactive for our health. But the reality is that we don't have any data for it, then we're probably just would be giving you side effects with minimal benefits, and there's just no data there to support it. But it sounds like you've been doing excellent. You're taking great care of your health, and that's that's all you can do, which is still it's still a lot. There's data to show some benefit in those things as well.
Thank you.
I also have a question. It wouldn't be COVID if we didn't ask a COVID question, right? But so my question would be do you as oncologists have any concern about the vaccination and how it might interact with some of the drugs that we are taking? I'm on Aromatase, and my thing is, it's the evil that we know as opposed to the evil that we don't know, right? So as oncologists, is there a concern saying, I wonder, I'm on the 10-year plan, I think, because I was just diagnosed and started treatment 2 years ago. So my question is, are we going to be looking at something, a few years down the road going, what do we do about that?
Yeah, it's a good question. We haven't studied the COVID vaccine among our cancer patients. Thus far, I haven't seen any signal that it has any interaction with any of our chemotherapy drugs or our anti-estrogen therapy. I think the one thing that we can say based on, what ASCO guidelines and our ASCO colleagues are sort of reporting is that there is a lower response rate to the COVID vaccine for patients who have had prior chemotherapy or are actually actively receiving chemotherapy, because they just may not mount as good of a response to the COVID vaccine. But other than that, I can't say that there's any downfall in terms of their cancer risk of recurrence or the efficacy of these drugs.
I also don't know of any other vaccine data that reports of, any other vaccines that have, been detrimental or interacted, although I know, it's a different type of vaccine, but just even thinking about the pathophysiology of it, there's nothing I can think of from an interaction standpoint that would be concerning.
It was kind of a loaded question, right? Because it's such a new vaccine and such a new virus and everything. So it's kind of like, I was just wondering if any flags went up with some of y'all thinking, oh boy.
Truly not. I mean, I was very honest with my patients. I mean, even probably once I got the vaccine, but even before, I'm pretty honest with everybody, for better or worse. But I wasn't just saying just vaccinate me before I knew anything, before any trials came out, before I knew who Pfizer was going to be the one. But as soon as I saw any of the data, I felt very, very comfortable. I had zero hesitation. I was chomping at the bit to get that email and to get signed up. So I don't know a single physician, honestly, who hasn't gotten the vaccine. And so I've been really happy and excited about the enthusiasm, but I do also say I think we see a very biased patient population, people who are willing to come to the doctor and things like that. So I know there are, not everyone's enthusiastic about it, but.
Thank you.
I have a quick question, if nobody else does. Sorry, guys, I'm not on camera. I have to do it so much for work. It's like, gets crazy. I was diagnosed 4 years ago. Well, yeah, I guess 2017, February, and started on Tamoxifen in May of that year. So I've been on Tamoxifen for almost 4 years, and I have lobular. And it was early stage 1, and like as good as it could be in that case. But lobular is a little different. I've gone down the rabbit hole of research with that. And I know that the aromatase inhibitors are a little better for lobular. But Tamoxifen I don't have. I'm lucky, I suppose, except for I'm the person who asked about vaginal atrophy. So if anybody wants to ask, I've had Mona Lisa, I've done every this and that and the other before I finally turned to a little bit something else. And that's one reason I'm sort of staying on Tamoxifen, but I don't really have any side effects from Tamoxifen except for that. So am I losing a lot, that 2 to 3% or so, by not switching over to the AIs right away? I'm just where I'm quote unquote menopausal. So is that a bad decision for me to stay on Tamoxifen?
So thus far, there hasn't been any data to say that patients live longer with an aromatase inhibitor over Tamoxifen. And I think having a stage 1 breast cancer also suggests that the benefits of the aromatase inhibitor versus Tamoxifen are small, and probably what you quoted, about 3 to 4%. So in my opinion, I think it's better to take Tamoxifen than take nothing at all. And I don't know that 2 to 3% is really enough to justify all the hardships that you noted with the aromatase inhibitor. So I would probably stay on the tamoxifen.
I guess the other question is, when you say you're just menopausal, is it, you know, you're just stopping your periods, or they've truly said you're menopausal for a long period of time and they've been able to do serial labs to say that that's kind of where you are, or
Yeah, it was just my luck of the timing or whatever. It was sort of, all of this happened when I was perimenopausal. So it happened naturally. And then of course, tamoxifen pushes you in. So yes, I've had a couple of years of straight, hormone testing and no periods. So I think it would be safe. But I just hate to think that I'm not doing the best thing, but I know with the AIs, and I also have osteoporosis, which is not really a surprise. I'm very petite. so I'm staying on tamoxifen right now, but I just, I don't want to cut out or feel like I'm not doing the best thing by not doing the AIs, because I know I'm aware of this information that they're a little better for lobular. So.
Yeah, I mean, again, I would agree with Dipika. I think it's just hard to say, but I think again, it's better than nothing. And I think you had, an early stage cancer, and that you're doing something. And I think the benefit is really pretty minimal. And God forbid something were to happen, it's impossible to say that if you had actually taken an aromatase inhibitor, anything would be different. So you just never know. But so I think that's, what you have to take comfort in knowing, because it already sounds like you're dealing with some hardships, and that's already challenging in and of itself.
And I have another question. I'm on Arimidex and have been for a year and a half now, I guess. Are the side effects, can they become cumulative? Because I hardly had any side effects or even noticed that, I was on it or anything. But lately I seem to be experiencing more hot flashes. So just wondering if I have that to look forward to, that it might be cumulative, the side effects.
I don't tend to find that they're cumulative, no. I mean, I always wonder if there's something else going on. Is there another change in medication, or change in season? Not suggesting anything, but are you drinking red wine instead of white wine, or drinking, sometimes alcohol can induce some things like that. So,
Oh darn, I hate when alcohol factors into
I know, I'm sorry. I mean, if you're willing to deal with the hot flash at night because of the alcohol, I'm not saying to stop. I'm just saying.
Okay, so red wine or white wine? Which one should I, if I want?
Red more, but I don't know. Just take a log. I always recommend keeping a log. So. Yeah.
Wait, but I mean, so seriously, red wine might increase the hot flashes?
I've heard, I feel like anecdotally, but not from an actual scientific standpoint, no.
And of course, I don't drink any at all because it's been advised not to, right? So I wouldn't even do that. But wink, wink, Leslie sees me winking. But yeah, I hear what you're saying. So yeah, it's probably seasonal.
Yeah, I mean, so that's not something that I've found.
Okay. They've actually done surveys on women who are on anti-estrogen therapy, and it seems that the peak of the complaints is really in that first 6 months of taking the anti-estrogen therapy. And then the complaints start to decline, whether it's patients get tired of complaining or they just get used to the side effects. I mean, I think clinically, I feel like patients actually get more used to the side effects of the anti-estrogen with time. So I wonder, if there's something else that's causing the hot flashes, and weather would probably be a good explanation, as well as it's warming up here. Maybe that's another explanation. Well, it did only happen one time, and I do think it was after I did a 2.5-hour bike ride or something. So it could be that, but
Exercise is good though.
Yeah. So thank you. And so is wine.
Anybody else? Well, I just want to thank both Dr. Moore and Dr. Misra. This has been an amazing presentation. Your slides were terrific and you explained everything so well. I think that's why we don't have a lot of questions, because you explained everything so clearly. But thank you so much for being with us today. This was amazing.
Thank you.
Thank you.
Thank you.
Happy to be here. Thank you.
Thank you very
Thank
much.
you.